Hi guys, and welcome back to Count to 10. My name is Ani, and in today's pod, we're going to cover the physiological changes that occur with pregnancy. My focus today is going to be talking about the cardiovascular and the respiratory system, because these are the ones that are commonly asked as SAQs. Just like our previous MiniPod formats, we're going to go through a learning objective, look at the past SAQs, and then look at some opening viva stems and how to answer them. So let's dive straight in.
1, 2, 3, 4.
Now, when it comes to pregnancy, we have to know some of the basic principles. Essentially, all the physiological changes that are occurring in pregnancy are so that the mother can provide nutrients to meet the metabolic demands of the fetus. As the fetus grows from the first trimester to the third trimester, the metabolic demands increase and therefore the physiological changes become more and more dramatic. There are 4 key factors that are driving these physiological changes. The first one being hormonal changes. So there's an increase in HCG. There's a production of a hormone called human placental lactogen, which is essentially like an anti-insulin hormone. And it makes sense having a hormone like this because you want the mother to be offloading all of the sugars, the fats, to the fetus and provide the nutrients. Then there's your classic hormones, estrogen and progesterone, which just have agonist and antagonist activity on each other. Estrogen helps to support the growth of the uterus and the breast, while progesterone promotes the storage of nutrients, and it also leads to a lot of the physiological changes that occur with the respiratory system and the cardiovascular system. The second main factor that's driving the physiological changes in pregnancy is the mechanical effects of the enlarging uterus. Just by the sheer size, the uterus growing will have a displacement effect cathalically on all the organs that are nearby it. Then the third main factor driving these changes is the increase in metabolic demands, especially as we get into the third trimester where those demands start to meet their peak. Then finally, the last major physiological change is this creation of a placental circulation, essentially acting like a low pressure AV shunt in our body. By the end of the third trimester, it's sucking up to 750 mils of blood per minute, which in a normal human being would be around about 15% of their cardiac output. So let's now focus in and look at specifically the cardiovascular and the respiratory system. Now, majority of what I'm going to talk about is mainly numbers. These numbers all come from Power and CAM, and there's no great way to remember them. You just have to rote learn them and look at the diagrams. The easiest tip I have is that majority of the numbers increase as you go through the trimesters, and they peak in the third trimester. What you need is a way to classify all the changes that occur in a system by remembering your big subtopic headings. So when we look at the respiratory system, these are things like your anatomical changes, your lung volumes, your lung mechanics, your VQ, your shunt, your dead space. When we look at the cardiovascular system, that's looking at changes that affect heart rate, stroke volume, cardiac output, peripheral vascular resistance, blood pressure. And then with each of these systems, the last subheading I have is something special that's related to pregnancy. So within the cardiovascular system, that's remembering to mention the aortocaval compression. Within the respiratory system, that's remembering to mention the rate of difficult intubation is increased and that the FRC is dramatically decreased. Then when you have your subheadings, you want to also think about the different stages of pregnancy. So this is your first trimester, your second trimester, your third trimester, and what we always miss is talking about what changes occur with labor and delivery, and then finally, when these changes all return back to normal. So with that basic overview of how we're going to look at each system, let's take a deeper look at the cardiovascular system. Majority of changes have already started to occur by the 8th week of pregnancy. Your heart rate increases by 20% by the end of the first trimester, and by 25% by the end of the third trimester. With that, the stroke volume is increasing by 20 to 30% by the end of the first trimester, and then by 40% by the third trimester. Why are these changes occurring? It's because they're trying to increase metabolic demand. The driving force behind the increasing stroke volume is the increased circulating volume caused by an activation of the renin-angiotensin system. If the heart rate and the stroke volume are increased, then the cardiac output needs to be increased as well. So by the end of the third trimester, the cardiac output is approximately 50% higher than the normal pre-pregnancy values. When you look at a graph that depicts all these three changes, what you'll notice is that they linearly increase to approximately halfway through the third trimester, and then they plateau out. The next increase is when they hit labor and delivery, which we'll talk about in a second. In terms of the peripheral vascular resistance, this decreases by 35% by the end of 20 weeks, and it's mainly due to a vasodilation effect due to the effect of progesterone, prostaglandins, and a downregulation of your alpha receptors. With this, you could imagine that the blood pressure decreases, and it reaches its new normal low values at 20 weeks. 20 weeks is a special time when it comes to pregnancy. It's a time where aortic cable compression can start to be diagnosed, and it's the time when you can start to diagnose preeclampsia. Then when we look at regional blood flow, the higher cardiac output is diverted to a lot of different areas. We've already spoken about the uteroplacental blood flow getting 750 mL per minute. The renal blood flow increases by 80%. Blood flow to the breast, the GI tract, and the skin all increase. And there's a good reason for this. You want more blood flow to the GI tract so you can absorb more nutrients. You want more blood flow to the breast because that's what's going to grow and supply the baby when they're born. So all physiological changes that are occurring all have a reason behind them. In terms of the special point with the cardiovascular system, we've already mentioned the aortic cable compression syndrome. So this is apparent in 15% of pregnant women at term. And like we said before, it can be seen as early as 20 weeks. It's quite simple to explain. There's the compression that's secondary to the growing gravid uterus that compresses the IVC. Now you have a blockage and decrease in the venous return, so therefore cardiac output is decreased, and then women get the clinical signs of having a decreased blood pressure, pallor, nausea, and vomiting, classically when they're supine. So that's when that left lateral tilt comes in of 15 to 30 degrees. Then when we look at blood volume in pregnancy, we get a disproportionate rise of the plasma volume as compared to the red blood cell volume. The red blood cell volume increases by approximately 20 to 30% by the end of pregnancy, but the plasma volume increases by 45 to 50% by the end of pregnancy. This discrepancy leads to the physiological anemia of pregnancy, where now the normal new hematocrit is approximately 0.3 to 0.35. Again, everything has its own reasons, so decreasing the hematocrit means that the viscosity is lower, therefore there's less resistance going to the peripheral tissues, so it's another factor that can improve the delivery of oxygen. Now let's focus in on the changes that occur with labor and delivery. In early first stage, you get an increase in cardiac output by 15%. By late first stage, that cardiac output bumps up by 30%. By second stage of labor, we're up to 45% increase, and right after delivery, we're up to 60 to 80% of those baseline values. This is due to the massive autotransfusion that occurs from getting rid of that uteroplacental blood flow. So now that 750 mL goes back into the mother's circulation. And this is a really important period in pregnancy. Most women will have a pretty robust heart, but women that have a cardiomyopathy or some kind of stenotic disease or pulmonary hypertension, that autotransfusion can be a very deadly period. All of a sudden, that heart can't cope with that increased volume, and a mother can decompensate very quickly. On the flip side, it can be a very beneficial thing. When you're doing a cesarean section and you have a woman with a bleed, the 750 mL all of a sudden is this increased blood volume that can help to compensate for whatever blood loss has already occurred. Now, all these cardiovascular changes that occur with pregnancy normalize by 2 weeks postpartum. And it just goes to show how quickly a body can adapt to a different condition and then revert back to normal. Let's now talk about the respiratory system changes. So anatomically, there are two big changes that occur. This involves the airway and the thorax. Within the airway, the vocal cords get swollen and edematous, And this is because of the capillary engorgement throughout the respiratory tract from the increasing circulating volume. The circulating blood volume of a pregnant woman is really easy to remember. So as you know, in a 70 kilo adult, we normally say that the blood volume is 70 mils per kilo. At term, we normally say that a pregnant woman has 100 mils per kilo of circulating blood volume. Then we have the changes in the thorax. These are mainly driven by the gravid uterus pushing the diaphragm upwards and cephalidly by 4 centimeters. However, the contractility of the diaphragm isn't affected with this upward displacement. The diameter of the chest wall also increases, and the total circumference of the chest wall and thoracic cage increase by 5 to 7 centimeters. This is mainly due to the effect of relaxin, which is produced by the corpus luteum, and it relaxes the rib ligaments. Then we get the changes in the lung volume. So the main lung volume that you must know is that the FRC decreases by 20% in pregnancy and by 30% if that pregnant woman is lying supine. That's a significant amount of FRC lost, and it's the reason why pregnant women have such a short apneic time, even with a preoxygenation of an FiO2 of 0.9. The total lung capacity is also decreased by 5%. The vital capacity, however, is unchanged, and the only capacity that seems to increase is the inspiratory capacity by 10%. When we look specifically at the minute ventilation and the alveolar ventilation, we get dramatic changes occurring compared to the cardiovascular changes that occurred linearly throughout pregnancy, peaking at the 3rd trimester. These changes in minute ventilation are pretty much complete by the end of the 1st trimester. The main reason for this is that the increase in progesterone stimulates the respiratory center and shifts the ventilation curve and the CO2 response curve to the left. Now all of a sudden we have an increase in rest rate by 10%, an increase in tidal volume by 40%, and a combined increase in minute ventilation by 50% by the end of 12 weeks. So if you're ever doing a case of a pregnant woman having a non-obstetric procedure and she's past the 1st trimester, the implication is that your ventilator settings need to reflect that. So the ABG changes that you would see would be a lower PaCO2 of approximately 30, a lower bicarb of 20, a base excess of -2, and a pH that's normal but slightly alkalemic at 7.42 to 7.45. So within the normal range, but at the higher end of the normal range. So just keep those changes in mind if you're ever doing an obstetric patient for a non-obstetric case. In terms of a pregnant woman's lung mechanics, the large airways become more dilated, so therefore airway resistance decreases. Because the large airways are more dilated, the anatomical dead space is increased, but at the same time the tidal volume is increased as well. So the ratio of dead space to tidal volume doesn't actually change. The lung compliance stays the same, but the chest wall compliance decreases mainly due to the engorged breasts as well as the cephalid displacement of the uterus. Therefore, overall, the respiratory compliance decreases by 20%. The fact that the compliance has worsened but the airway resistance has decreased, these two things offset each other, so there's no actual increase in the work of breathing. That's different to a pregnant woman saying they have subjective dyspnea. This is just focusing on the work of breathing. Then when we look at the respiratory system during labor, what you can imagine is a pretty predictable increase as well. Mainly the minute ventilation increases during contraction due to pain, as well as the contraction causing an increased O2 consumption. And sometimes after a contraction, you might see a transient hypoventilation occurring. This is because the increase in minute ventilation during the contraction drove down the CO2, so that after a contraction was finished, the drive to take the next breath was suppressed, and sometimes women in this state can also have a brief desaturation. After delivery of the baby, unlike the cardiovascular system where it took 2 weeks for everything to go back to normal, the respiratory system is much more quicker at adapting, and it's mainly because you've lost that progesterone by taking away the placenta. So the FRC and the residual volume all increase and return back to normal by 48 hours because the uterus is no longer there. the tidal volume declines within 5 days. The only thing that takes a bit longer is that you can still expect a bit of airway engorgement just because the circulating volume is still high and there's still the capillary leakage and engorgement occurring. So just because a woman's postpartum doesn't mean that she might not still be a difficult intubation. So that takes us to the end of our first part, where we covered the learning objective, described the physiological changes and their implication for anesthesia that occur during pregnancy, labor and delivery, in particular the respiratory and the cardiovascular system. We didn't really talk about the hematological or the GI system. Those are pretty self-explanatory. And really, there's no past SAQs on that. The money lies in knowing the changes that occur with the respiratory system and the cardiovascular system. So now, let's look at some of those past SAQs that ask those questions. The last question that was asked was describe the physiological changes that occur in pregnancy within the cardiovascular system back in 2022. This had a pretty good pass rate at 60%, and as per the examiner report, the elements required for pass included the direction and magnitude of change in pregnancy of the major cardiovascular parameters, some explanation of the mechanisms behind these, and then a description of the aortocaval syndrome. You can see, as long as you had a good structure talking about heart rate, stroke volume, cardiac output, peripheral vascular resistance, BP, and then remembering that every system has its own special heading, and the special thing within the cardiovascular system is aortocaval compression, you would have probably been happy to see this question come up. So if I was to write a model answer for this question, I would start off with a generic statement that physiological changes in pregnancy aim to accommodate an increase in metabolic demand to help allow the fetus to grow. And as pregnancy progresses, these changes within the cardiovascular system increase. You can say here that the key changes are the increase in blood volume and an increase in cardiac output, and that these are driven by placental hormones that increase demand. Now I know that some model answers will have graphs. I don't think you need to put them in, but if you can't remember what the graph looks like, just remember majority of the graphs within the cardiovascular system in pregnancy are linear, going up to midway through the third trimester, and then they kind of plateau out. Then to help me draw the graph, I would just remember what the value of each parameter was at the third trimester, and then usually half that value for my first trimester value. For example, the heart rate increases by 25% by the third trimester, approximately half it'd be 15% by the first trimester. Same with stroke volume, 40% by the third trimester, approximately half it'd be 20% by the first trimester. Again, with the cardiac output, 50% midway through the third trimester would be around about 20% to 25% by the first trimester. That technique works well for heart rate, cardiac output, and stroke volume, but not so well for peripheral vascular resistance and blood pressure. Those values reach their low point at 20 weeks, and the way I remember that is by 20 weeks, that's when we start to diagnose patients with preeclampsia. Then you can also put in your graph with what happens to red blood cell volume, plasma volume, and total volume. You can argue and say this is actually the hematological system, but looking at the examiner report, they kind of wanted you to put that in with this answer. Always then remember to talk about labor and delivery. You'll always get marks for saying that the autotransfusion occurs after delivery and that cardiac output increases progressively from the first stage of labor in the early phase, the second phase, and then the second stage of labor. Then you complete your answer by talking about aortocaval compression and the significance of that and why that occurs. And I think this is a pretty straightforward question, which, like I said at the start, if you have a structure, you'll do well. The only other question that was asked was in 2019, which was discuss the effects of pregnancy on the respiratory system that were relevant to the practice of anesthesia. Include in your answer how these influence the conduct of anesthesia. So again, this question is leaning towards taking your physiological knowledge and then applying it to a clinical setting. It would be a hard question to answer if you haven't worked in a place that does obstetrics, but just go on your first principles, use the basic rules, divide the question up into the changes that occur with different trimesters, and then have your big subheadings for your respiratory system. Here you could almost have a table where you have your big subheadings for your respiratory system and the implication of those changes for the conduct of anesthesia. Again, to start this question, I would have that blanket statement of why changes occur in pregnancy to help support the metabolic demand, and that these changes are driven by hormonal changes and by the mechanical effects of the growing gravid uterus. I would start off by talking about the anatomical changes. So the airway changes being increased mucosal swelling due to the increase in the renin-angiotensin system leading to an increased plasma volume and the vasodilation. You get the breast enlargement, which affects your ability to put the laryngoscope in, and then once you get an airway view, you have an increased risk of a difficult intubation by 8 times normal. The other anatomical changes is that you have the laxity of ligaments due to the production of relaxin. Your chest wall compliance is decreased, your lung compliance stays the same, and overall your respiratory compliance is decreased. You have bronchodilation that occurs in your upper airways and your trachea, which decreases your airway resistance. And your dead space is increased because of that, but your dead space to tidal volume ratio stays the same because your tidal volume is also increased. What is the implication of your dead space to tidal volume ratio being the same? Well, your end-tidal CO2 gap between your end-tidal CO2 and your PaCO2 stays the same. Then we can talk about lung volumes, and remember the main lung volume that you can't miss out on is talking about FRC. That decreases by 20% when you're upright and 30% when you're supine, and then you get that further decrease when you're having a GA. So that means you have a lower oxygen reserve. Combined with the increased metabolic demand, you're going to have a very short apneic time before you start desaturating. The clinical implication of that is you want to have your best person doing the airway. You want to maximize your chance of airway success on your first go, so use a video laryngoscope and an intubating aid such as a bougie. And then the other implication of this is that as the lung volume decreases rapidly, you might need to do some recruitment maneuvers to help increase the lung volume again. Then you can talk about your minute and alveolar ventilation and say that these changes occur early in pregnancy and are complete by the end of first trimester. You get an increase in rest rate by 10%, an increase in tidal volume by 40%, and a combined increase in minute ventilation by 50%. These changes are driven by progesterone changing your sensitivity curve to CO2. And with this, we get changes in our ABG, which is a low PaCO2 of 30, a slight alkalemia, a low bicarb. The clinical implication of this is that you change your ventilator settings for a woman under a GA that's pregnant, and a faster minute ventilation also means a faster wash-in of inhalation agents and a faster washout. Then to complete the answer, you can talk about the changes in labor, so you get the increase in minute ventilation with contraction, and then between contraction or right after a contraction, you can get that transient hypoventilation occurring, which can lead to a brief desaturation. Again, sticking to a structure with this SAQ, knowing your subheadings and talking about each trimester, and then specifically answering what the examiners wanted here, so relating those respiratory changes to how your conduct of anesthesia changes, was the real key in this question. This brings us to our last part of the MiniPod, which is looking at the previous opening viva stems. This feels like I'm repeating the same things over and over again, but it's just trying to make you have a system to answer it. So the last opening stem was from 2022, which was what factors are responsible for causing physiological changes to a woman's respiratory system during pregnancy. And here you start off broad again, so you go back to the basis. What were those physiological changes that we spoke about right at the start of the podcast? It was those hormonal changes, the mechanical effects of the enlarging uterus, the increasing metabolic demand, and the placental circulation. So that's where you would start this opening viva question, and then in your head you would have an idea of what would be your next answer to the next question. So if I was answering this question, I would say there are many key factors that influence the physiological changes to the respiratory system during pregnancy. These involve hormonal changes, mechanical changes due to the enlarging uterus, increasing metabolic demands, and the placental circulation. and just stop there and let the examiner guide me to where they wanted to go. In my 2-minute perusal, I'd be thinking of the different subheadings, so the anatomical changes, the lung volume changes, the lung mechanic changes, the ventilation changes, and the ABG changes, and thinking about how I categorize those in terms of first trimester, second trimester, third trimester, and then what happens in labor and delivery. The other viva question that's been asked as an opening STEM in 2013, well, what are the cardiovascular changes in a pregnant woman at term? And I think cardiovascular changes just lends itself much easier to your memory bank, because you can just talk about heart rate, stroke volume, cardiac output, blood pressure, peripheral vascular resistance, and then special things being aortic cable compression. That brings us to the end of today's MiniPod. And this is really a 2-part MiniPod. The next MiniPod, I'm going to focus in and talk about the fetal circulation and then the changes that occur with the fetal circulation at birth. And then I'm going to tie in the neonatal airway and the neonatal respiratory system and how that compares to the normal adult respiratory system. I hope you guys have enjoyed listening to this pod. And if you like my content, subscribe to the YouTube channel and check out the website Sweet Dreams Anesthesia. As always, you can message me at anirudh@sweetdreamsanesthesia.com with any questions you may have. And I wish you guys the best of luck with your